My name is Alejandro Mesa Palmeros from Mexico. The title of my work is Risk Perception, Coronavirus and Precariousness, a reflection on fieldwork under quarantine. This work is a reflection about a dialogue sustained with a group of women from a neighborhood of Monterrey, Mexico, where I have spent the past year conducting ethnographic research. This group has been a kind of a door that have permitted me to get in the neighborhood and to start sharing the everyday life of the inhabitants. On the evening of 18 March, I received a message from Mrs. Lourdes. She urgently asked me to come to the neighborhood of La Campana, Monterrey, the next day. The group of women with whom I have been discussing health-related issues for the past several months had called an extraordinary meeting. This meeting was to decide the continuity of our weekly meetings in the face of the COVID-19 contingency. Despite the fact that in Mexico the social distancing measures imposed by the health authorities to deal with the pandemic were not officially decreed until 23 March, messages were already circulating on social media demanding the implementation of preventive measures. Some sectors of the population influenced by these messages anticipated the great confinement. The meeting took place in informal tone, alternating laughter, restless glances, and silence that expressed a feeling of generalized uncertainty. In this article, I analyze some fragments of the conversation held in this meeting from the perspective of medical anthropology and the theoretical approach to risk. The pandemic configures a risk scenario that combines a sense of imminent danger and the responses that social groups generate in the face of uncertainty and misfortune. But it is necessary to consider that the notion of risk is profoundly rooted in moral judgments that define responsibility. I consider for this work that a condition of precariousness has a determining influence on the definition of risk, since it restricts the material possibilities of its containment, but also because it produces a structure of meaning that conditions its perception. For this analysis, I decided to use Schepper-Hughes and Locke's approach and distinguish three categories: the individual body, the social body, and the political body. From a social and cultural perspective, risk perception is a fundamental object to study. In this article, I have only outlined some analytical proposals that require further development. I tried to construct a conceptual line that contributes to the understanding of human behavior in dangerous situations, focusing my attention on the interaction of the population with political and health authorities. Medical discourse, inseparable from political discourse, is reproduced and constructed to the media and generates multiple prescriptions and significations. Likewise, I have tried to demonstrate the analytical relevance of body precariousness in its phenomenological, symbolical, and political dimensions. Those objects as a valuable interpretive tool in the investigation of risk, its perception, and the meaning of the adoption of some practice to confront threats. Many of these practices have been characterized as irrational, by some sectors of the population, especially health personnel. I want to end this very brief reflection by saying that social science have a fundamental role to explain and to understand the configuration of specific risks, such as this pandemic, and also the population behavior in front of these kinds of dangers.
Hello, my name is Henry Kwok. I am the author of the article entitled Beyond the Anti-Racist Reason, a Postcolonial Perspective on Pandemic Politics. I would like to make a few points to understand the pandemic, not from a public health perspective, but from a sociological point of view. During the pandemic, there are a lot of concerns about the rise of racism against Asians. A lot of people are very worried about the fact that the image of yellow fever or segment of Asia is coming back. But I want to scratch beneath the surface and look at the politics of health during this crisis from a postcolonial position, through two examples, Hong Kong and China. Now, what I mean by postcolonial perspective is similar to what the late British cultural theorist Stuart Hall describes. That is, what happens after colonialism, or the after effects of colonialism and imperialism in our healthcare system during the crisis. I argue that if we don't understand the past, especially the imperial or colonial past, and how the past is connected to the here and now, it is very difficult to understand what's going on and the pandemic politics. I argue in the paper that the virus or the pandemic is not just a scientific issue or a public health issue. The new virus, in fact, triggers a lot of fear in the post-colonial context like Hong Kong. So the virus exposes the contradictions of health, politics, and development which have not been resolved. In the first example, I mentioned how the current healthcare system and the quarantine policy in China is still haunted by the legacies left by its communist or Soviet past, even though the country has achieved tremendously in terms of economic development and scientific progress. In the second example about Hong Kong, I explore what remains silent behind the xenophobic attitudes of the Hong Kong medical staff during the pandemic. Some medical staff in Hong Kong threatened to hold a general strike as a tactic to pressurize the government to close the city's border with the mainland, and the purpose is to stop the mainland patients from using the healthcare systems and facilities in Hong Kong. Now, one may say that, these workers don't care about the health of the mainland compatriots. But if we use the post-colonial perspective, we may have a different interpretation about their apparent xenophobic attitude. The health crisis is intimately linked to the problematic past of Hong Kong and the political complexities under the constitutional order of one country, two systems. It also triggered people's memory about the marketized and neoliberal turn of public health policy, which actually incentivized the boom of birth tourism by the mainland mothers. And of course, the crisis also triggered the traumatic memory of the mass protests against the extradition bill last year. Now, all these issues add up to the identity crisis of the people in post-colonial Hong Kong. If I may put it in medical terms, I would say that the virus triggers all these social complications. To put it in a very simple way, health politics is also post-colonial politics. A post-colonial perspective invites us all to look beyond the apparent discourse in this global public health crisis, such as racism. A sociological perspective on COVID-19 is not just to prescribe solutions to the current problems, but a sociological perspective can get us into thinking about how various domains in social life are deeply connected to one another. So a virus is not just a biological or public health issue. It is also a political issue. Thank you.
Hello everyone, my name is Sabina Yasmin Rahman. I'm from Assam in the northeastern region of India, and I'm very glad to be able to contribute a perspective on COVID-19 pandemic from India. My paper, titled Social Distancing During COVID-19, the Metaphor and Politics of Pandemic Response in India, is a comment on India's response to COVID-19 and its implications to public health in general. The central argument of my paper is that although conventionally public health is viewed as an evidence-based profession that is above politics, national responses to COVID in India reveal that health and illnesses are concerns that are embedded in the larger politics of the state. Although it's still early to assess the full spectrum of damage caused by a lack of central level planning, the paper argues against COVID-19 being viewed as a great leveler, or that everybody is in this together. In the wake of the pandemic, public health authorities in India presented a contradictory picture, exposing marginalized communities to further risks and deprivations. To illustrate this point, I have used three distinct events, which to my mind sum up the deeply entrenched structural inequalities that mark the pandemic experience specific to the Indian context, and present themselves as the most enduring sources of dysfunction in our society. Naturally, some of these reasons also contribute to state failure in providing a coherent, scientific, planned response to the current global health crisis, and in helping to promote social solidarity rather than deepening existing inequities. The first instance is that of Islamophobia, following an international Tablighi Jamaat congregation held at Nizamuddin, New Delhi, that reportedly became the first super spreader in India. But the fake news that has paralleled the rise of right-wing supremacist politics across the globe aggravated the damage by stigmatizing all Muslims for political point scoring and portraying them as a perpetual threat to the health and safety of the nation, resistant to treatment, modernity, and science. The second equally disturbing trend that emerged alongside the global anti-Asian and anti-Chinese sentiment was racism against migrant communities from the northeastern region to mainland India. While Northeast Indians are routinely perceived as foreigners, usually Chinese, and are subjected to violence and derogatory name-calling, now they were being called coronavirus. Such racism in India has barely received serious academic attention even today. The third aspect of the pandemic, which has caused maximum preventable deaths outside of COVID, is the plight of poor rural migrants in the metropolitan cities and industrial towns, constitute the larger chunk of the unorganized sector. Despite being the backbone of the Indian economy, they have faced the worst fate during the pandemic period, during the lockdowns. The prospect of contracting the virus and dying away from home or family during the indefinite lockdowns resulted in panic and uncertainty that forced thousands of daily wage laborers to throng the streets and set on a homeward journey on foot, since there wasn't any other means of transport at this point. As a consequence of breaking the lockdown protocols, they also became subject to disproportionate force in the hands of the police. Indian economists lamented the lack of planned action and globally coordinated strategy, and identified the inefficient and repressive response of the government as the root cause of acute economic distress facing the urban migrant poor. It's feared that more people would die of hunger and loss of livelihood during this period than the virus itself. Here, my paper extends Turner's concept to suggest that we inhabit somatic societies and regularly employ the vocabulary of pathology and disease to determine social health. The Indian experience during the pandemic indicates that far from being an apolitical notion, social distancing provided yet another occasion for the state to dominate, govern, and regulate unruly bodies. Moreover, by unleashing its most mechanical form of control on its vulnerable citizens, the Indian state seemed to be suggesting that it is more focused on surveillance to discipline and produce docile bodies, meaningful only as long as they can be productive and be of service to the neoliberal state. The body in any other way embodied resistance and a threat to the rationality of the state. In conclusion, I'd like to say, my paper tries to say that for a society like India, that is already structured and segregated on lines of caste, class, race, religion, gender, social distancing becomes somewhat of an ironic proposal. It becomes a measure for the state to co-opt scientific interventions of risk mitigation and relay them to people as a metaphor for exclusion, thereby exacerbating deeper structural inequalities around which access to health and well-being of the population is organized. Thank you so much.
Hi, I'm Kelly Thompson. I'm an associate professor at York University in Toronto, Canada, and I'm happy to have the chance to talk to you about the paper that I contributed to the special issue of Health Sociology Review that focused on the coronavirus pandemic. So I was very happy to have the opportunity to contribute a paper to the special issue because I was really fascinated, I think like most of us, trying to figure out what was happening as the pandemic was unfolding around the world. And one of the things that really hit me was how there seemed to be a lot of variation in the way political leaders were responding. And I often have an interest in what a gender lens can tell me about what's going on. And I got very interested in how gender seemed to inform the type of responses that political leaders were adopting. And when I'm talking about gender, I'm not talking about sort of biological sex differences, but instead thinking about cultural post-essentialist perspective on gender, and particularly what is the gender order in a given society in terms of what behaviors and ways of performing one's identity are seen as the right way to do things. And in North America, certainly, there is a patriarchal gender order which sees masculine ways of being as being superior to feminine ways of being. And when we think about that in the context of how to respond to a pandemic, in terms of the way, a masculine way of responding is, men are expected not to flinch in the face of danger, to take risks, to take care of business, to not be concerned about, their personal safety. Whereas a feminine way of behaving in response to emergencies is to be caring, to be concerned about other people, and ultimately to take a more cautious approach. And so when I saw the way the pandemic was unfolding, I was particularly interested because of course, most of our political leaders are men, and certainly the Canadian Prime Minister, Justin Trudeau, is a man, although he does identify as a feminist, whereas the President of the United States, Donald Trump, is also a man, but he performs his gender in a much more traditional, macho, masculine way. And so I was looking at the sort of double bind that hegemonic masculinity creates for leaders as they started to craft their response to the pandemic. There was a tension between, shutting things down and trying to limit the spread and being very concerned about the impacts on health versus this more, take care of business and push forward despite the risks. And so that's the substance of the paper, is looking at the sort of way in which gender creates a double bind for a man who does not sort of adhere to this macho approach. That may mean that they're seen as less of a leader. And that applies to people in leadership positions in general. So that's the substance of the paper. I considered the impact. If you look at Canada and the US, Canada has about, per capita, about half as many deaths, less than half as many deaths as the United States. And the United States has 5 times as many cases on a per capita basis as Canada. So I think the social science lens has a lot to contribute to understanding things. Science has focused on things like, how the virus spreads and how we respond to it in terms of things like vaccines. But when we look with a social science lens, that helps us understand how people act and that impact on spread. So what makes people resistant to wearing masks or resistant to social distancing. So that's the substance of the paper. I would love to hear any feedback you have. Thanks, and enjoy your meeting.
Hi, I'm Jared Goggin.
And I'm Katie Ellis.
And we're the authors of a recent article for Health Sociology Review on disability, COVID, communication, and life itself is the title of the paper. And when we write about COVID particularly, and we take a perspective from critical disability studies, it's a new and emerging interdisciplinary area of social sciences. And I think we really feel that the social sciences bring incredibly important perspectives to bear on understanding social life. If you think about COVID, the COVID times we're living in, the many challenges, many of them have to do with social behaviour. They have to do with social arrangements, and they have to do with the meanings and practices, very intimate, personal, important collective practices. And that feeds directly into public health issues, for instance. And it also feeds directly into to health itself. And so, one of the things that we talk about in our paper in our way is the way that we imagine life itself and imagine society has often remained very disabling. It's often still has disabling images and stereotypes and actually widespread exclusion of people with disabilities. And one of the things we draw attention to in our article, I suppose, using social science perspective, is to say we can see that when societies around the world, places around the world started to talk about how to respond to COVID and, for instance, who might be prioritised for health and medical care, often there are assumptions brought to bear about whose lives were worth more than others, and that potentially people with impairments and disabilities might be people who might not receive the priority for health care and otherwise that everyone should. And so just, I suppose, starting with some of these tools of looking into how society is organised, we found is very important to bring to bear to understand COVID and to bring to light issues that have now started to get widely discussed around people with disabilities. So, Katie, how would you see, the work we've been doing in relation to social sciences?
Well, I think one of the interesting things about our paper is that we did come at this investigation of disability and COVID and how people with disabilities were sort of framed during COVID from two different parts of the world. I'm here in Western Australia, you're in Singapore, and we saw that there were some really similar reactions to people with disabilities, perhaps in being treated as dispensable in some ways, but then there were also some social interventions that took place. For example, the shopping hour that was introduced in both of our areas, but they were reacted to in quite different ways in Singapore as related to Australia. And I think through examples like that, we can see that disability is in many ways constructed through society and in different ways within society, depending on what things we're valuing.
Yeah, look, I think that's right, because I think disability has often just been taken to be a kind of medical issue, right? Seen on a medical deficit model. And I think one of the important things, as you're saying, to understand, disability in different places is to understand the different cultures and the languages. Singapore is a multicultural, multi-ethnic society with different languages very much in play. And to some extent, disability is an emerging issue here. And I think that's a really interesting contrast as well. So there was very much a kind of reaction, as you were pointing out, with shopping hours to say, look, here's an hour where people with disabilities and older people can go and get access to the shop. I think there wasn't a thinking through of a bunch of other issues about, how people with disabilities, what the reality of people's lives are in terms of getting access to shopping, and whether a wholesale shift, as has happened to online shopping, is possible. I mean, one of the issues it raises is around accessibility, for instance, but all sorts of things, delivery, logistics, a whole set of issues around, how we then reorganise life. And I think maybe the insights in reflecting on the work that's coming from social sciences, from disability studies, is to say that actually this gives us more broader insights into how different societies are organised.
And I think the fact that we did see a complete reorganisation of our lives and how we do things as a result of COVID, people staying home, staying safe and shifting to online shopping and online everything, saw some more inclusion for people with disabilities.
Yeah, yeah, that's an interesting insight. I mean, do you want to talk a little bit about that? Because I think one of the things that we were sort of drawing attention to is to say, for many people with disabilities are going, yeah, okay, well, sort of welcome to our world.
Yeah. A lot of people with disabilities did say, in some ways my world is better, but still, we did point out the fact that there were some restrictions still and some disabled ways of approaching people with disabilities in this context, not making sure they had everything they needed, not ensuring they were able to access the online shopping and delivery hours when everyone was doing it. So for the people with disabilities who actually needed these sorts of supports to get through life, when all of a sudden everyone else was doing it, again, we see that people with disabilities were being pushed down to the least valued group, I thought.
Yeah, that's right. And I think there's a kind of paradox here that, we've often wondered about, I suppose, and tried to analyse, in the sense that, with pandemic, as you were saying, that many people with disabilities who'd been participating often remotely, but that participation, if they were, say, working part-time, was often not well understood, when the normal is like the full-time kind of worker. But on the other hand, there's different kinds of inaccessibilities and digital inequalities. And I think one of the things that's come up in, say, digital inequalities research in a study that's just been published by social scientists from the Netherlands is to say, actually, things were exacerbated during the pandemic in relation to digital inequalities. And I think that's something that really would, merit further research around disability and accessibility too.
Mm-hmm. Absolutely. I've been doing some more work on students with disabilities and how they've been included and excluded during the move to online learning as a result of COVID, and, you know, speaking to a whole bunch of lecturers and students with disabilities who found that, you know, they were further disadvantaged and weren't able to actually participate in this online world.
Yeah, that's right. And I think there's a whole set of other issues, aren't there? I mean, I think one of the issues that came to light perhaps more in Australia than the Singaporean context, where it hasn't been so well discussed, is because of the National Disability Insurance Scheme in Australia. I think at a certain stage, people were saying, hey, there's been public policy about PPE, the personal protective equipment, for people working perhaps in medical context and for doctors and nurses and even people in aged care. But what about in disability care, in you know, say the NDS scheme and others? And I think there are a whole set of issues there about really inequities and a lack of recognition of some of the issues of people with disabilities and their families, communities, carers, and so on.
Yeah, and I think there was a real lack of understanding about what the NDIS did provide for, certainly at the beginning of the pandemic, where people were saying, you know, people with disabilities shouldn't have extra access to things like whatever they needed because they've got the NDIS, which, you know, that doesn't pay the extra amount, you know, the increases we saw in grocery prices and things like that.
Yeah.
So I saw a divide coming up again early on, not so much now, where we're seeing, you know, more discussion about disability after the aged care.
Yeah, that's true. I think there's been some, in the Australian context, some things lining up, haven't there, in terms of the disability, you know, kind of public discussions with Royal Commission, the Ageing Commission and so on. In Singapore, that's not so much been the case. I think around disability, things have been a little bit more in the background. But there was an important seminar here around disability and work inclusion and digital inclusion at work as a key theme around disability and how to improve workplace participation with people with disability. And I know this is an area where Australian researchers particularly have been starting to do work that I think has been really important as well.
One of the ways we are coming to know COVID-19 is through the mathematical model and through projections produced by mathematical models. With COVID-19, the mathematical model in many ways has gone very public, almost domesticated. We have become used to talking about R, reproduction number, and of flattening the curve. These are social concerns, public concerns, not mere concerns of science or calculus. And it's these ideas which we draw upon in our recent paper in Health Sociology Review. In our paper, we take the model as a site of public trouble in COVID-19 infection control. Our analysis seeks to follow the numbers, that is, to follow the projections of some of the more predominant models, and trace how these move from the model into social life and public concern, as well as public policy change. This analysis is being done by myself and Kari Lancaster at the University of New South Wales and London School of Hygiene and Tropical Medicine in the UK. The analysis takes the model as a performative actor, and this means we're less immediately concerned with the model or modelled projections in terms of their precision or accuracy, and much more concerned with what models do. That is, in the realities they create, in the futures they imagine, and in how they are put to use and made to matter in actions as well as policy, in the material effects they make. This means our analysis is focused on the model as a form of ontological intervention. To do this analysis, we follow the numbers or projections of two predominant models in relation to the COVID-19 pandemic. These models were produced around February or March and came to public attention actually towards late March in the UK. The first of these models is produced by a team at Imperial College and focuses on infection control. it works with three main scenarios of doing nothing, of mitigation, and of suppression or lockdown. The model, released in late March, coincides with a quite abrupt, dramatic policy change in the UK, which moved from vaguely communicated ideas of herd immunity to much more stringent controls of lockdown. This abrupt policy change, but also the science surrounding it, and specifically the projections being released from this Imperial College model, fold into a great deal of heightened public interest and concern. There is quite a lot of controversy around the policy change and indeed the science informing it, or said to inform those policy changes. What we find by tracing the projections produced by the model is that far from being fixed or stable, far from transcending their context, they're very much situated and materialized within these. They become fluid, very multiple, very excitable, as these projections are worked and reworked and transformed in light of the deliberations and the contestations going on around the herd immunity to lockdown policy shift. The model becomes a site of public travel. What this tells us, or what we take from this, from the analysis, is that we treat modelled projections, and indeed all enumerations, far less as matters of fact, as if they have some kind of correspondence to a reality out there, and much more as matters of concern, as they fold into social concerns, public concerns, and also issues of politics. This work, I guess, focuses on two or three things of interest, perhaps. The first is how controversies or contestations around knowledge are quite illuminating and make visible how science is being made, and more particularly how science is being made through deliberation and through politics. Secondly, we are noting the very public nature of the model as a form of governance, as a form of anticipatory governance in the time of pandemic and COVID-19 in particular. We notice the model as a kind of boundary object which has the capacity, given its latitude, to incorporate many different forms of expertise, including those beyond science. And this leads us to argue towards a more participative, more deliberative model, a way of doing modelling beyond that which is done now. And lastly, I think we see this paper as an example of how sociology can respond quite rapidly in an unfolding and a fast-moving situation, such as a public health emergency, as is the case with COVID-19, which throws up a lot of uncertainty, where science is being made in a very quick and emergent fashion. This points us, I think, to the value of sociology in reflecting on science as it is being made in the now, which alerts us to how science can be made differently, of course. Lastly, a paper in Health Sociology Review offers an example of how sociology can respond rapidly, as well as in the moment, in the context of fast-moving, as well as uncertain emergencies like pandemics, like COVID-19. COVID-19 challenges very much some of the mainstream assumptions of an evidence-based intervention approach to doing science and intervention, and it encourages us towards a much more fluid and emergent way of generating and reflecting on knowledge as we go. A rapid sociological reflection such as this in the context of the emerging evidence making of COVID-19 through modelling is an example in a way of how sociology can have a praxiographic entanglement with the objects which it's studying. At the same time, of course, the reason for reflecting on science as it is being made in the now is also to reflect on how such science and policy might be made up differently in the future.